Okay, so now we are starting with another part from neonatology, and there is a difference table which is very important, and we have to understand the basic differences between these because these two things are quite oftenly seen in a newborn. So, head swellings of newborn. This is a page from my notes, and I'll be using it to make you understand easily what are the differences between cephalhematoma and caput secundum. So, cephalohematoma is basically a subperiosteal hemorrhage involving the cranial bones. So, what happens is that the cranial bones, right? These are the cranial bones, and this is the periosteum, and there is a hemorrhage in the subperiosteal region, and because there is absence of periosteum between the joints, they do not cross the suture line. So this is a very important feature that we have to understand in case of cephalhematoma, it never crosses the suture line, right? So this is cephalhematoma. Because of subperiosteal hemorrhage, there is swelling in the head of the newborn, right? While in case of caput secundum, it is more oftenly seen in case of neonates. There is simple edema in the layer of scalp, right? Scalp के layer में there is edema, and because these are the layer of scalp, and you can see here is the periosteum. So the soft tissue of the scalp gets swollen, and as a reason of which it can cross the suture line, right? So coming to the next thing, that the cephalhematoma, it takes nearly 24 hours to completely to reach its maximum size, while the caput secundum, it is already present at the maximum size at the time of birth, right? So this is the point number two. Then the third point, it takes nearly 5 to 7 weeks to disappear. Cephalhematoma is a serious thing here, right? So it takes 5 to 7 weeks to disappear, and it disappears within 2 to 3 days. Okay, the child is born with caput secundum, and within 2 to 3 days it gets disappeared, right? So, and the last point, this predisposes to neonatal jaundice while it does not, right? Cephalhematoma, because there is subperiosteal hemorrhage, there is leaking of blood outside, so it predisposes the child to neonatal jaundice, while in case of caput secundum there is no such predisposition. So this is the difference table that is very commonly asked in the viva. So coming to our important topic, that is neonatal resuscitation protocol, because I've used the pages because it is a flow chart, and we have to understand the things in a flow chart manner, right? So coming to this, so first of all, it was I'll use a different color maybe. Yeah, this one feels good. Okay, so it was first of all given by the American Academy of Pediatrics. Right, no, this is not a good color. It was given by the American Academy of Pediatrics in 2015, right? So according to it, nearly 10% of neonate need some form of resuscitation at the time of birth, and out of those 10%, nearly 1% of the cases, they require chest compressions, right? Chest compressions are required by 1%. So before I go with this, I would like you to understand that whatever I have written in blue, these are the new guidelines, while the black one is the older ones, right? So the new guidelines is that before we start, right? Wait. Okay. So before the starting of the neonatal resuscitation protocol, an antenatal counseling is done, in which the parents are told, like, there are certain conditions in which the child, there is probability that child may land up in situations where the child require a resuscitation. There is team briefing and equipment check, right? There are certain equipments that we'll be seeing are used in the resuscitation of a neonate. So as soon as the child is born, few things that we have to ask or we have to see as a pediatrician. The first thing is that whether it is a term gestation, whether the child is a term gestation. The second thing, the muscle tone of the child. Is the child is having a good muscle tone, like if all the muscles are completely extended and the child is not moving, it's completely limp, then the child may require a resuscitation, right? While if the child is in complete reflection and the child is breathing or crying, so if the child is having these three things present, right? If the answer is yes, the child is a term gestation, good muscle tone, and the child is breathing and crying, so What we do is that we take the child for routine care. It stays with the mother. We provide warmth to the child, and it is something that we have to keep in mind. The recommended temperature in the delivery room is 25 degrees centigrade, right? And we clear the airway if it is required, right? So there are conditions in which the child may have aspirated something, so we clear the airway, and in clearing the airway, we start from mouth to nose. The reason being, if we start from nose, then by the time we reach the mouth, the contents of nose might droop in. So it starts with mn, the letter m comes first, so it starts from mouth and then it goes to the nose. The catheter that we use for suction is 12 to 14 French, and the pressure that is applied in that catheter is 80 to 100 80 mmHg or 100 centimeter of water, right? We dry the baby and we go for the evaluation of the baby. But if these conditions are not met, right, if there is some problem with this, we go to the another step of NRP. That is, we do the rest of the things like the one we were doing in the routine evaluation and evaluation part of this. We provide warmth to the baby. We give a proper position to the baby such that the neck portion, we put it a bit in an extended form so that the airways are cleared, and then we clear the airway if required, and then we dry the baby and we stimulate the baby by tapping on the foot and on the back side of the baby. We do it very gently, and then we assess the heart rate, right? We go for seeing the heart rate of the patient. If the heart rate of the child is, whether it is less than 100 per minute, or if there is apnea or any gasping, right? So if the answer comes out to be no, the child's heart rate is more than 100, but there is some labored breathing or there is some cyanosis, then what we go for is 3 C's we do, right? We clear the airway, we check for the saturation, check saturation, clear airway, and consider CPAP, that is continuous positive airway pressure, right? So we check for the airway, we check for the saturation using a pulse oximeter, and then we consider using continuous positive airway pressure. This continuous positive airway pressure will help dilating the keeping the alveoli is dilated. And this is the new guidelines, that we can supplement oxygen if it is required, right? If the child improves, if it's just that these labored breathing and cyanosis starts getting disappeared, we take the baby to the post resuscitation care, where the baby is taken to an NICU. Its temperature is monitored and other things are assessed, right? So this is what we are doing when there is no fall in the heart rate below 100 and there is no apnea and gasping. But if it is present, what we do, the very very important step in the NRP, in fact it is the most significant step in the NRP, we start with positive pressure ventilation, also called as bag and mask ventilation, using an ambu bag, right? So at this, we are using an ambu bag and we are giving bag and mask ventilation, right? And this is very important to remember, that it should be started within the first 60 seconds after the birth of the child, and the first 1 minute is called the golden minute of life, right? So and then we check for the saturation, and this is the new addition, we can consider using a cardiac monitor. So after doing PPV for about 30 seconds or so, we again check the heart rate of the baby, right? So when we check the heart rate of the baby, if it comes out to be less than, we see whether it is less than 100 or more than 100. So if it comes out to be a no, then we directly take the child for a post resuscitation care. But if the heart rate is still less than 100, we check the chest movements, right? We are pushing air using the ambu bag, and if still there is no rise in the heart rate, we check whether the things are properly connected or not, right? Here I would like to give you some ventilation corrective steps that are to be followed, right? Maybe this. So we check the tech ventilation corrective steps. For this, there is a mnemonic MRSOPA. What is this MRSOPA? M is to see if the mask is properly applied or not. The bag and mask ventilation mask is properly applied or not. If it is not applied, reapply, right? Reapply the mask. S stands for suction, suction of secretion. Suction of secretion is done, and if even then there is no change in the heart rate, then we open the mouth. These are the ventilation corrective steps, right? We open the mouth, we go for positive pressure ventilation, and then we try to look for alternate airway, which includes endotracheal intubation, right? Endotracheal intubation, we can look for that. Okay, so if after that the heart rate starts coming to normal, right, then we go for the post resuscitation care. But if still it is less than 60, right, 2 times 100 and 2 times 60, if it comes out to be less than 60, then we do 6 very important things. We start with the chest compressions, right? These chest compressions are coordinated with positive pressure ventilation using bag and mask. And earlier when we were using bag and mask ventilation, when the heart rate was just less than 100, at that time the oxygen saturation was it was just 21%, right? But now we have connected everything, and the oxygen saturation that we are using now is 100% oxygen, right? After that we use cardiac monitor and we intubate the baby, and we start looking for a venous channel through which we can push certain things if required, right? So we go for umbilical venous catheterization, and it is the excess of choice during neonatal resuscitation, right? Again, if the heart rate is less than 60 or not, right? If it is more than 60, now we check if it is more than 100. If it is more than 100, we go for post resuscitation care and team debriefing. But if again it comes out to be less than 60, we inject adrenaline, right? We inject adrenaline. And regarding adrenaline injection, I would like to mention a few points. Adrenaline injection, the dose, right? Wait. Dose of adrenaline injection is 0.01 milligram per kg per dose, right? And it can be given up to 3 times, right? 0.01 milligram per kg per dose, or if I write it in ml, 0.1 ml per kg per dose, right? 0.1 ml per kg per dose, it will be given 3 times, right? Route of administration, it can be IV or IM, right? If it is through IV, we'll be giving most probably through umbilical venous catheterization. But if we are giving it intratracheally, right, intratracheally, then the dosage changes out to be 0.05 to 0.1 ml, milligram per kg per dose. And the strength of adrenaline is 1:10,000, right? So this was about the adrenaline. So even after the injection of adrenaline 3 times, the child is not responding and the heart rate keeps on falling. At a higher center, we might consider hypovolemia or many other or some other conditions, right? So this was all about the neonatal resuscitation protocol. So let us have a quick look over it. And coming to some other things, age and target saturation, right? Age and target saturation, what is this? So the time at which the child is born and what should be the target saturation. This is the saturation which we are trying to achieve. So just remember 60-65 and keep on adding 5 to it, right? So at the first minute is 60 to 65%, second minute 65 to 70, third minute 70 to 75, fourth minute 75 to 80, fifth minute 80 to 85, and after 5 go to 10, 85 to 95, right? So this is the PPV, positive pressure ventilation device, that I was talking about. This is the bag and this is the mask, right? This is the bag and mask. There are two inlets in it, right? One for the oxygen and one for the reservoir where the oxygen is delivered to the baby. So in conditions like we started with the baby without connecting anything, in that condition there was no oxygen supply, no reservoir, and the oxygen, fractional oxygen that was being given to the baby was just 21%. When we started with the oxygen supply, it nearly doubled to 40%, and when both of these things were connected and started, in that condition, okay, something, okay, fine, in that condition it became 90 to 100%, right? So this was all about these things. Let's come to some of the other things that are asked and that are important in case of this, right? So the rate of oxygen, right? The rate of oxygen delivery, it is about 40 to 60 breath per minute, right? This is the first thing that we have to keep in mind, right? The pressure required to deliver a breath to the neonate, pressure, right? Pressure that is required if we are giving the first breath, right? When we are talking about the first breath, it is 30 to 40 centimeters of water, right? And the subsequent or second breath, then it reduces to half, 15 to 20 centimeters of water, right? Now there is a thing called absolute, right, contraindication to bag and mask ventilation, and it is congenital diaphragmatic hernia, right? So what basically happens in congenital diaphragmatic hernia is that see, right, if this is the baby, this is the chest of the baby, so generally there is diaphragm, right? Diaphragm is completely formed, and here we have the abdominal loops and all those things, and here we have the lungs, right? So what happens in congenital diaphragmatic hernia is that these walls are not properly formed, as a result of which these bowel loops go inside the lung, right? So what happens is that when we start bag and mask ventilation, right, if it goes into the liver, lungs, that's all right. But if by accident it goes into the esophagus, and if we start pushing the air, this bowel loop starts getting dilated, and the lungs start getting shift to the other side, so there is mediastinal shift, right? And this lung hypoplasia and mediastinal shift are the condition which are going to get worsened if we keep on pushing the air into the esophagus, and it will keep on going into the to the lungs, which will further deteriorate the condition of the baby, right? So these are the things that we have to keep in mind. Now the single most step in the NRP is PPV. I've already told this, right? And the single most indicator that we have to look for is heart rate, right? So these are the things that we have to keep in mind. Okay, what about the endotracheal intubation? Endotracheal intubation, the laryngoscope that we use is a straight one, right? Not the bent one, because बच्चे सीधे होते हैं, straight kids are very straight, right? Also in the laryngoscope there are two sizes, 0 and 1, 0 for preterm, right, and size 1 for term neonate. What else do we have to know? Size of endotracheal tube. And the size of endotracheal tube is basically, it is based on the birth weight, gestation age, and the size, right? Size in millimeter. So I'll give you a chart that will help you understand. If the birth weight is less than 1000 gram, or say the gestational age is less than 28 week, right? The classification that we were talking earlier. So the size of the tube will be 2.5 millimeter, right? If it is less than 1500 gram, or say no, wait, if it is from 1000 to 2000, right? 1000 to 2000, or if the baby is from 28 to 34 weeks of gestation, then the size is 3. And if it is more than 2000 grams, or the baby is above 34 weeks of gestation, then the size is 3.5 millimeter. Yeah, this is what we have to remember. Now that you have intubated the baby, how would you check if the intubation has been done properly, or how would you confirm whether the ET tube is in trachea? So ways to confirm: correct intubation, right? Ways to check or confirm the correct intubation. Wait, I'll change the color. Okay, so the first thing that you can see is that there is bilateral rise in chest, right? With each breath, as you are pushing the air, the chest is getting raised, right? Improvement in vital parameters, right? Or when you will put a stethoscope on the chest of the baby, there will be bilateral audible breath sound, right? Fourth, what can be seen? The ET tube, we will see misting of ET tube. What does it mean? The vapor, right? Vapor arising from the lung, they are coming in the ET tube, and then it is clouding it. The fifth and the most important one, this is clinically the most important one, and tidal carbon dioxide, EtCO2, also called as capnography, right? It is the most accurate method to confirm that the ET tube has actually gone into the trachea and not into the esophagus, right? Now, some other things like the chest compression, right? Chest compression. What about chest compression? How do you do it? First of all, where do you do it, right? So it is at the site just below the nipples, right? It is at the site just below the nipples and at the midline. This is the place, right? At the midline, on the lower 1/3 of the body of sternum, right? Midline, lower 1/3 of body of sternum. This is the place where you do it. How do you do it? The technique is two thumb encircling technique. This is how you do it, right? And how deep you go. Suppose this is the baby and this is the chest of the baby. How deep you are supposed to go? You are supposed to go 1/3 depth. So this is how you do it. And what else? Recommended ratio of chest compression to ppv, it is 3:1, right? 3 chest compression and 1 ppv. In 2 seconds you will do 3 chest compression and 1 breath. This is how I do, right? Alright, so few more things. Condition in which we do not resuscitate the baby, right? Conditions in which we don't resuscitate. So what are the conditions where we are not resuscitating the baby? Anencephaly, right? There is no need of resuscitating the baby, because anyway the baby is not going to survive, right? If there is a confirmed case of trisomy 30, you won't resuscitate, right? If the gestational age is less than 22 weeks, it is very difficult to help the baby survive in such kind of condition. There is another thing that I want to tell you about. Delayed cord clamping, because now that we are delivering the baby, we should understand all these things. Delayed cord clamping. So how much delay? 30 seconds, right? Wait for 30 seconds before clamping the umbilical cord. It is recommended in all the term and preterm neonates, right? So let us talk about the advantage of it. Advantage of delayed cord clamping. First of all, there is decreased chances of anemia, right? What else? There is decreased need of blood transfusion, right? There is good blood pressure, right? Good blood pressure. What else? There is decreased risk of NE, necrotizing enterocolitis, which we will be talking about in subsequent classes. What else? There is decreased chances of intravascular hemorrhage. So these are the reasons why we should go for delayed cord clamping. Disadvantage. The disadvantage of delayed cord clamping, as we have already talked about, is there is increased risk of neonatal jaundice. Okay, fine. So these are the things. What else do we do after the baby is born? We give an injection of vitamin K, right? 1 milligram, just 1 milligram IM is given so as to prevent any hemorrhagic disease in the newborn, right? If there is any hemorrhagic disease, it will prevent it, right? And if the birth weight of the baby is less than 1 kg, right, we will give 0.5 gram, just this one. And then we initiate the early initiation of breastfeed. We will talk quite a lot about this breastfeeding and its benefit in the subsequent classes. Maintain the normal temperature of the baby, 36.5 to 37.5. We will talk about hypothermia also in the subsequent classes, right? And before we discharge the baby, we do the immunization. What are the immunization that we are going to give in just after the baby is born? BCG, OPV, hepatitis B. These are the 3 vaccines that we are going to give, right? We screen for all those things. Screening will be done, right? Screen for jaundice, right? Start vitamin D supplementation, 400 unit per day, given for 1 year, right? So these are the things that we are going to do before discharging the baby. So this is all about it. We'll be starting with some other topic in the next class.